Oh,
Oh gosh.
okay. Kristen, would you like for me to introduce you, or are you happy to
Sure,
introduce
go ahead.
yourself? How do you want to,
That's fine.
Okay, awesome.
Go ahead.
Yeah, I'm just going to read from the sort of the snippet that you sent me. So, I think if this is everybody we're looking for to get started, I'll go ahead and jump into it. So this is Kristen. She is awesome, grade A badass. You guys are really lucky to have her on today. She's been in healthcare for almost 20 years, started out as a lifeguard, got her bachelor's degree in exercise phys. She's worked a lot of clinical roles in and out of the hospital, a lot of pre-hospital stuff, and that boils down to her role as a paramedic. So super interesting for what we've got today. She's worked in the wilderness realm as a firefighter paramedic for the National Park Service in the U.S. She's volunteered with state search and rescue teams. She's also been a rural flight medic and is on a U.S. disaster response team. She got her master's from the University of Exeter as an international student and has traveled to a whole bunch of countries for that, practicing and learning medicine in her spare time. She enjoys being active in the mountains near her home in Utah and trail running. Oh my goodness, you're crazy for that, with her husband and two dogs.
Thank you
Thanks
very
for
much,
being here,
Kat.
Kristen.
Yeah, thanks for the intro. And nice to meet you all. Hope that I will give you some insight into the world of flight medicine. I know anybody in here international, or is most people here from the US?
Oh, I know that I'm based in the US.
Okay, no problem. All right. And if you guys want to pop off mute and interrupt me at any time, more than welcome to ask questions, or you can type in the chat. Hopefully someone can monitor, because I'm not sure I can see it from my screen. But all right, so here we go. So we're going to touch on just kind of wilderness medicine, specifically as a flight medic. Let's see. So here's a little bit about me and my wilderness hat. So I say a little bit untraditional as a paramedic, since I did work some 911 and have worked in the city. But my first taste of being a paramedic was in a big city of probably about 3 million people, about 15 years ago, and there was 7 different paramedics crowded into a bathroom doing a stroke scale and deciding which hospital, that we had 4 of them with a 5-minute range of that we should go to, and if it was worth starting an IV. So I learned very quickly in that environment that I'm like, I'm not any good here in terms of what's my role. So I quickly moved across the country into the most remote place I could find that would give me a job, and ever since I've been going pretty remote. So worked everywhere from the National Park Service. I love working kind of event medicine out in the middle of nowhere. So up there you'll see, let's see, that's Red Bull Rampage is a bike competition, I guess you could say, of Red Bulls and everywhere else in between. Some of these are just as my role as a flight paramedic, having to get the patient to the helicopter or the airplane. Maybe we couldn't land right next to them, so you have to put on a little bit different hats and maybe lash up to a dog sled or an ATV in order to go get the patient. So as a flight medic, worked both fixed wing and helicopter. And in here you can see the glorious COVID days when we had to have way too much PPE and all the different things that had interfered with our jobs doing that. Just to talk about some conflicts of interest before I get too in the weeds of talking about flight medicine, I do work for leadership right now for a big nationwide flight company. So I do have some decision-making ability within the medevac world. I also own and teach a wilderness education company, but not related to this. And this is a completely separate topic than I talk about or teach in that realm. So during this presentation, I'm just going to touch on some common air transport vehicles that you might interface with or see, and then discuss the kind of unique environment that we have in the flight world. And then we'll talk about the 6 main stressors that patients and providers experience during flight. And then we'll talk a little bit about physics and some gas laws and how to mitigate those things that you're going to be affected by in flight. And then the main signs and symptoms for both you and your patient. So first, just looking at some flight providers and their education. So here in the U.S., most medevac companies require or fly with a nurse medic role, and both of those roles they usually look at you having about 3 years of experience at the least. They really like having ICU experienced nurses, so more time in a CV or neuro ICU or just a regular ICU, because they kind of want that critical care long term brain of the nurse, and then the how to work out in the field, on the side of a highway or the side of a mountain that the medic has, and how to stabilize really quickly and what to recognize for those immediate interventions. So that's why those two roles really work well together in order to have that, what do I need to do now and first, and then how do I maximize that maybe for the longer transports. Helicopter EMS kind of varies all around the country to maybe 5 minute response times to maybe you're flying for an hour or so. Or more, depending on how rural it is. And then the fixed wing aircraft or airplanes really fly really far. There are, speaking of some providers, there are some companies in the US that staff nurse practitioners, so the NP role. You also will have some of those really critical care flight providers or flight services that will transport like ECMO and Impellas and balloon pumps and other things, and they might staff a perfusionist, maybe a respiratory therapist. I've also flown with a neonatal nurse practitioner that would hop on if we knew we had those kinds of flights. So for the most part, these providers are going to be very specialized and experienced, but it really varies according to the service and the area. Overseas, there are doctor medic interfaces or some medic, but in the US, it's very rare to have two medics on a vehicle together, just because it's not considered to be critical care at that point. So first, looking at some helicopters. So this right here is actually an A-Star. It's a small helicopter that's supposed to do really well for long distances and high altitude. As you can see, it is pretty small inside, and we'll touch on that in a little bit. But these aircraft are not going to be pressurized. Almost every helicopter in the US that's flying HEMS or medevac transport is going to be flying low enough that we don't have to worry about a pressurized cabin, which we'll talk about the difference of that. Another really important thing to talk about with helicopters is the night vision goggles. So you'll see over on the bottom corner, there's my helmet with my NVGs mounted on them. And at least the pilot is mostly on NVGs, but during non-patient care legs, almost always the rest of the providers are on NVGs. And that is so that we can look at our what's around us, make sure we keep an eye on other aircraft or birds or anything else. Drones are a big issue right now, trying to keep the air safe. So it's not just like driving down a road where, or maybe in the back of the ambulance, you might be able to have a snooze. It is you're awake at all times and keeping an eye out and looking for all those different hazards that you have around you. And that's a whole certification that has a whole bunch of regulations that you got to upkeep.
Quick
Here's some
question: how
of course.
how cool do you feel wearing those goggles?
How cool. Terrible. They
Yeah,
hurt
the
my neck.
NVGs.
They are very heavy. So they're really cool when you first learn how to do them, but then you learn really quickly to hate them because they're heavy. It pulls your head forward, and so your neck is always constantly trying to fight on the way back. And then you're only looking out of this little tiny tubes, and you have to adjust them to make sure you have enough light. But it's sometimes really cool to see lightning out of them, or I've got some pictures looking out of the mountains and stuff. But for the most part, we all hate NVG flights. Or airplanes. So here's some airplanes that you'll see on the screen. Let's see, I think that's on your upper left-hand corner if I'm oriented myself right. You'll have the Lear jets. So that is we call it a Pepsi can in the sky, but it's a very small interior because it's built to be very fast. So this kind of airplane is going to be for really long duration flights, maybe over oceans, maybe across the country, that you've got kind of hours and thousands of miles to cover. That Learjet is a Lear 35, I believe, and it can fit 2 patients in it, and then an additional 4 passengers in addition to the 2 pilots that are required. I didn't speak too much about pilots when I was talking about personnel, but the pilots also have to have a significant amount of hours in order to qualify to be able to fly. So for clarification, the nurses and medics have nothing to do with the operation or very little to do with the operation of the aircraft. That is done by pilots, and the pilot will be in complete control over getting you from A to B, kind of like your Uber driver. And then we just do complete patient care. The rest of the crew is certified to do some things kind of like a flight attendant, maybe a little bit more than a flight attendant, as we are considered air crew. Over on the opposite side of the screen, you'll see that that's actually a Beechcraft King Air 200. So that is also a larger aircraft, but it's a turboprop. So you can see it's got propellers on it, and it has 2 engines, one on each side. And then there on the bottom, you have a Pilatus PC-12. And the really cool thing about this Pilatus is the loading door. So these, that Learjet and that King Air 200, they have very narrow doors. If you think about if you climb up into a single person wide door, trying to slide a patient on a bed with all the equipment can be really hard through that tiny door. But this PC-12 down here, it's got this big cargo door. I wish it was open in this picture. But so the pilot can climb in and out of these stairs, maybe a provider or 2. And then on that back side of that 4th window that you see there, it's this huge cargo door. So it's really easy to get equipment in and out, as well as the patient. So you can see here we're landed at the airport, and we've got an ambulance that's coming to, most likely there's a patient inside, and they're going to load them up and drive us to the hospital inside that ambulance. Right there in the middle is kind of your average hangar. So as you can see, sometimes you have multiple different assets within a hangar. So you might respond to a call via ambulance or pick the correct aircraft depending on how far away you're going for the call. So this is the interior of that Pilatus. So it's one of the very common medevac planes. It is a single engine, so just one engine, but is a fantastic aircraft. As you can see, it looks super nice on the inside. You got these big leather seats. The 2 providers face each other with the patient right next to them. And so this first picture is looking from the back cargo door forward. So you can see where the pilot and the cockpit is, everything in there behind those wood paneling. And then on this other side, this is looking from that first captain's chair, that provider chair, looking back. And this one is set up that we're getting ready to pick up a patient. So you can see here, we've got our monitor. Behind it is a Revell ventilator. And then over to the side, we have hooked up on the IV pole. We wrapped up all of our vent tubing because we're ready to pick up a vented patient. And then we have a bunch of pumps with some of our medications pre-spiked because we know that what we're going to need, and it's going to save us some time for that patient. That yellow thing on the bed there is called a life blanket, and it has different layers so we can adjust how much warmth we want to provide for the patient, but we wrap every patient up in that life blanket to keep them protected and to help us move them around. So the other things you can kind of see in this aircraft, it's not just a private plane with with a bed thrown in and some seats taken out, but it's a medical interior. So it's got that stainless steel on the side in order to make it easier to clean. We install or they install suction on the wall. So you can see the containers down low, and we've got the adjuster up high. And then further down on that wall, we have connectors for both medical air and oxygen if we need it. That seat kind of that you see behind the bed, sometimes we can take a patient's a family member or a provider or maybe a trainee if we're teaching someone how to ride along with us or to train them for future. And then back behind it, you can kind of see back in that darkness, that's our cargo hold. And what that is where we can stash all of our stuff. So think about how far away everything is. Everything by the FAA is required to be restrained and strapped down, so there's no moving pieces. It's just like how on the commercial aircraft you have to stow all your bags under the seat or in the overhead compartment. So anytime we're moving, we have to have everything stowed back there. So it's really important to figure out what you need and get it before you lift off, as then you might not be able to get to it until you get to cruise and there's very little space to move around. So that's kind of the inside of the plane. The last thing I want to touch on in terms of vehicles, this is a caravan. So it's kind of the combination between a helicopter and an airplane. It's got a little more space than a helicopter and requires to have a landing zone. So you've got to have an airport or a landing strip to land on. However, it's non-pressurized. We'll talk more about what pressurization really means in a little bit, but there are aircraft that have to fly pretty low and they cannot fly up in the clouds with all the commercial planes. So the first big thing we have to think about when we are flying in a medical helicopter or airplane is space. So you think that you see in the movies these big Black Hawk helicopters or these big airplanes that we fly on all the time for commercial of how much space we have. These medical aircraft are not that big. We have to get into some small runways sometimes, so we can't fly big aircraft there. Plus, those big aircraft are very expensive to run, and we don't need all those people on board. So these small aircraft are usually what we end up using. So if you look over here in this first picture, you've got this is inside that A-star I showed you on the earlier slide. So here's your patient bed. And then you've got your ventilator, oxygen, monitor, and all that stuff mounted right there in the middle. Right on the other side of that partition, you've got the pilot. So the pilot and the patient are right next to each other, which can be a big thing if you're worried anything about safety. So that patient needs to be sometimes medically or chemically restrained or sedated in order to be compliant. Because imagine if anybody gets scared or moves around at all, there's not much space in there to do much. This black right here is actually the provider's knees. So their feet are right by the patient's head, and their head sometimes ends up going right but kind of between the feet, and you got to lean down or lean over in order to do patient care. That second person sits right next to them and behind the pilot, and as you can see, they don't really have much they can't reach and interface with the patient. So that person is kind of like if you imagine the doctor at the foot of the bed, doesn't really do much but kind of oversees the whole thing. So they look at all the paperwork and the labs and the charts and the vent and the patient presentation and is kind of giving orders or suggestions almost to that provider. Some systems require you're hired for one role, so you sit in that seat and you do that one job all the time. Most of the companies that I've worked for, we swap back and forth. So I might do a call where I'm primary patient care, and then the second call that we go on, then I'm doing the charting and the overseeing while my partner does that. And that helps us keep good at all of the things of our labs and diagnostics, and also doing those interventions and patient interface. This other picture over here, as you can see, there's actually a patient loaded in here, but this is in that, this is a King Air 90, so a little bit smaller of a plane than what we saw earlier, but it has 2 engines. So as you can see, this one has a bench seat inside, and this patient is pretty much on this provider's lap. And the provider taking the picture, as you can see, again, has no real access to the patient, but maybe might be forced to help and kind of do an intubation or an airway management if they had to. But again, all of that equipment is kind of back there behind that cargo net. So it'd be really hard to get to anything if you aren't prepared and have it out beforehand. Okay, so that's kind of the ins and outs of the vehicles and the training. So let's talk a little bit about what we have to worry about once we get the patient in this environment. So there are kind of 6 main stressors of flight. We'll go through each one of these on the following slides. So the first is altitude. We probably in the wilderness realm hear a whole bunch about acclimatization and altitude sickness and how we need to like climb up slowly and maybe station somewhere in order to acclimatize to that environment. As you imagine, we aren't able to do that in an airplane. So our option is to pressurize the aircraft. And what that does is it simulates like almost like a barometric chamber that tube in the sky is now simulated to be at another altitude, and that way we don't have to worry about acclimatization. But as you can imagine, if this were to fail for some reason, we would lose consciousness really quickly, or in a duration of time, because we're not prepared for that altitude. So this chart is pretty standardized of what altitude you're flying at, and if you were to lose pressurization, how much time your useful consciousness. You might be conscious after, but you're not going to have those fine motor movements. You're going to start talking and slurring like you've had way too much alcohol, or maybe you're having a diabetic emergency where you're slurring all your words, is kind of how it sounds. But it's just you're so hypoxic and you aren't able to function very long. And so if you were to succeed that useful consciousness time before you're able to appropriately put on oxygen, then likely you aren't going to survive. And unfortunately, this has happened in a couple of aircrafts that you can investigate and look more into through NTSB. But seen here, as you can see, I'm sitting right here taking this picture, but this is what it looks like when that oxygen deploys if you lose pressurization. This picture is actually on the ground, and someone accidentally hit the switch, which is why we're not rushing to put it all on. But there's a lot of information about how to seat that. And as you can imagine, with headphones and masks and other things, it can be delayed. Just to speak a little bit on how high we fly, the Learjet is, again, oops, I'm going ahead of myself. Sorry about that. Okay, that Learjet that flies up with its jets very fast is very good at flying in the jet stream, which is probably what you're used to flying in commercially. So it's going to be flying at that 30,000 feet up to that 45,000 feet, depending on the area and the weather. And but most of these smaller turboprop airplanes, depending on the mountains and other obstructions that we have in the area, typically fly between that 20 to 28,000 feet. Just because, we're not going to benefit from the jet stream being such a small aircraft, and it's not made to fly that high, and the pressurization, if we were to lose it, would really you've got that 9 to 15 seconds at that high altitude. So it's better to fly low, and then also if something else happens, we're better gliding down in those 20,000 range. What would cause a depressurization, you might ask? Mostly it's some kind of hole that would penetrate through the fuselage, which is that place that we all sit. So if you were to accidentally, let's say, have someone discharge a weapon and the gun shoots a hole in the wall, that would cause pressurization. Some of the more common causes are door seals. So if you don't seal that door very well, or maybe didn't have appropriate maintenance, making sure that seal is really tight when the door is shut, that is the most common, because that door will blow off and then the whole cabin will depressurize. I've actually had it happen where we were missing one tiny little screw, and we were just not having massive depressurization, but just having problems keeping that pressure up. I'm going to talk more about pressurization moving forward, so I'm going to wait that. So pressure. So this, we know that as we go up in altitude, the air is less dense. So we have less oxygen, or less of everything per unit area up at this altitude. So gas is further apart, and everything is going to expand. So think about anything that you have in that aircraft is going to expand. So in the helicopter, where we're not pressurized, it's going to expand to the altitude we're flying. In the pressurized aircraft, is going to expand to what we pressurize the aircraft to. And that has a lot of math that's involved. But if you look on these considerations, there's lots of different patient presentations and illnesses that might be a problem, as well as some of our interventions. So some things like endotracheal tube cuffs, we're going to check for cuff pressures and potentially let out or let air in, depending on where we are in flight. So that's another intervention that we have to be checking on routinely. Some things like pneumothoraxes, they might be small and they might not be tensioned at sea level, but we have to keep an eye on it because it might tension with that gas expansion up at altitude. Most of our infusions, we do not carry any glass infusions, and we mix usually everything in bags or syringes. And then we don't really let anything free flow. We put it on a pump, just because even if we take all the air out, there's going to be small amounts of air inside that might cause those drips to go faster or slower depending on our pressure. But you also might need to decompress some things. So we put in OG tubes very frequently. You might have to monitor if you can vent sinuses or the GI tract or other kinds of problems. Or maybe you aren't able to take a patient because you are not in a pressurized aircraft, and going up too high, you're not going to be able to manage that head injury or whatever the patient complaint is. So the next concern is temperature. This picture here is in the helicopter. So the nice thing about the helicopter is as we go up in elevation, we are able to cool off. We're flying here, I think, at like 12,000 feet, and it still was 96 degrees. We do have an air conditioner on board, but it is not like your car air conditioner. And there's very little, we can't really open up a window very well to get some airflow, so it can get very hot. But we have to be concerned about that on the flip side of if it's very cold outside and we're going up in elevation, it's going to get colder. So trying to provide heat and in a stable environment for our patient can be difficult sometimes. So there's some that your Gay-Lussac's law is going to be the one that we're talking about here, and some different factors include like how hot it is outside, if there's humidity, what pressure you're at, the altitude, and so forth. I've been talking about cabin pressure a whole bunch, but here is some kind of chart and information about what kind of altitude and what kind of pressures you're looking at. So we have to do a whole bunch of math in order to figure out what altitude we are able to fly our patient at. The more pressurization, if we need a sea level cabin, so that means I need my patient to remain at sea level type environment, that means we might have to fly really low, which may or may not be possible based on mountains or other obstructions or the route that we're taking. It also burns a lot more fuel, and we might not be able to fly as fast at different altitudes. So these are discussions we have to have in depth with our pilot as soon as we understand where we're going with our patient and what kind of concerns we have at the patient. Most of the time, we try really hard to set our altitude for our destination, because then our patient won't experience much of an altitude change from when they're in the aircraft to our destination. I mostly fly in mountainous regions, so that usually is no problem for us. But if you're flying sea level for a long time, or flying sea level to sea level, that can be really difficult to achieve, and you need to figure out what altitude you're safely able to transport that patient. And sometimes the answer is it's not possible, and you have to take your patient a different method. So sometimes we end up hopping in an ambulance and going for a really long drive if we're not able to fly them. For any reason, especially in a helicopter or a non-pressurized aircraft, if we fly above 12,500 feet, the FAA requires that we all go on oxygen. And so if we're flying in Colorado in the helicopter and we have to go over some 14,000 peaks, sometimes we might go around the peaks in order to fly below that cutoff. Or sometimes we are just going to we don't have enough fuel, or we can't get around that front range without hitting those altitudes. So we all are wearing a separate medical oxygen than what we have for the patient. We have to have special hookups to be able to go on so that we can put the emergency masks on and other kinds of things on top of it. This is just, as you can imagine, because of the hypoxia and those delayed decisions and bad decisions that we might make if we're not realized that we're being influenced by that hypoxia at those altitudes. So everyone has been in a commercial flight, hopefully, and you know that it might be a little bit noisy in there, but you're comfortable enough to like have a conversation. These smaller aircrafts, you're much closer to the engines and to a bunch of other systems, and it can get really noisy. So that's part of the reason why we wear noise canceling headphones. One is so that we can hear and talk to ATC, which is air traffic control. So I hear every time that my pilot is talking back and forth with air traffic control, and I have to limit my speech so that we can have those conversations appropriately with knowing where to navigate and listening for those directions. But this noise, it fatigues you a lot if you don't realize it, and if you aren't wearing your headsets for some reason, maybe you're talking to your patient, it can cause a lot of fatigue. So we, at most of my companies that I've flown with, we have policies that state that the patient has to be on some kind of noise canceling, and we provide that for them. Usually it's an earmuff, or sometimes it's those disposable little foam that goes in the ear. But they triggers a whole bunch of cortisol in the system, and it wears you out. So imagine a patient who is now already having lots of cortisol fluctuations and under a lot of stress from a really bad sickness. Sometimes it's going to stress out their body a lot more, and they can circle the drain real quickly in flight. So it's one of those things that we have to foresee ahead of time and try to mitigate as much as possible. Vibration is another huge one. So the aircraft, whether it's the rotor on top of the helicopter has a vibration, or the fixed wing aircraft also just have vibration. And we're not talking about turbulence, we're just talking about like engine and air conditioner and heat type of vibrations that occur. And if anyone's ever been in a helicopter, it's like, oh, I'm just taking a 20-minute flight, no big deal. And I've done 20-minute ambulance rides, and it's going to be just the same. And at the end of the day, after you've done 3 of them, you're like, why am I so tired? I didn't really do that much today. And this vibration really wears you out, because it increases your metabolism, you burning off more energy, and it really stresses out your body, whether you realize or not. We also tend to sometimes drink less water because you're in this contained aircraft. You don't know when your next bathroom stop is going to be. And so you are just dehydrated, and you're burning off all of this water from the vibration. So the low frequencies below 10 hertz can cause significant muscle fatigue. So you don't even realize it, but it's almost like you went for a 10K run, even though you've just been sitting there in the aircraft all day. Flicker vertigo. So this is something that can occur anytime you have spinning props. So that would be the propeller either on the aircraft or front of the aircraft, or out the wing, depending on if you're single or double engine, or it happens most commonly in helicopters. So here's a nice picture. You can't quite see the propellers, or the rotor in this picture, but when that blade passes over the sun, it causes this flickering of the light, and it circles so fast that you see just like the light constantly flickering. And it really affects people differently. Some people never had flicker vertigo ever. Others might be fine at 1 revolution, like for instance, I might feel fine at 10 cycles per minute of that flickering, but if you get to 12, then I'm done, and I start having all these nausea, vomiting. I can get really dizzy and spatially disoriented, and it has happened that people have been rendered unconscious from this flicker vertigo. So we try and mitigate it with blinds, so we cover up the windows if we can, wearing sunglasses or some kind of eye protection. We put sunglasses on the patient if it's going to be a problem. But those propellers on the planes, it mostly affects the pilots, because it might be during sunrise or sunset if they're flying in. It just happens to go right through those propellers. So it's something that we make sure that we're interfacing with our pilot, and that he can see okay. Sometimes if they're flying under instruments, they'll put blackout curtains over the windshield, and it's like you look up there and you're like, oh my god, you're flying without being able to see outside. But they don't need to see, they just need to have the instruments, and if they just fly based on instruments. So it's pretty interesting. So this flicker vertigo is a big deal, and we try to mitigate it as much as possible, because it can be pretty dangerous. So G forces with acceleration and deceleration. So sometimes in takeoff, you exhibit significant G forces to get the plane off the ground in order to defy gravity to get the plane up in the air. So a normal takeoff, if there's no extra power involved from a short runway or anything like that, is about 1.4 Gs. So think about gravity, you're just multiplying it by about half, or adding about half as much. So it's a little bit way down, but it's not too big of a deal. You might feel pushed back into your seat a little bit. If autopilot happens to kick in and try and divert you somewhere, the autopilot is normally calibrated to move at slow increments, but sometimes the pilot might be forced to make an extreme maneuver. I had an instance where we were flying and a commercial aircraft was flying at the wrong altitude and got within a couple 100 feet of us, which was a pretty scary moment, but our pilot said, hold on, and just cranked over to the side in order to avoid having a collision or an incident, and that G forces was probably about 3 Gs for us, and it was like holding on, and it exhibits a lot of force. So we have to think about, for a normal healthy person, it's a little bit uncomfortable, but it's not a really big deal. But certain things can decrease your tolerance for those G forces. So up there on the bold ones are the biggest ones, and man, those are the top 3 are things that we as providers experience almost every single day. I just told you I don't drink a whole lot of water because I don't know when my next bathroom is going to be. I do not have a bathroom on my aircraft. I'm tired all the time from getting woken up at 3 o'clock in the morning and doing a 6-hour flight. I'm hungry because I'm missing my food and my stops. And then here we are, we're giving a ton of medications to our patients, or maybe I'm taking a medication for, if I have a sinus infection and I'm trying to mitigate that pressure in my sinuses, or a headache from my helmet and I talked about my night vision goggles being uncomfortable. So I might be taking stuff, and that can affect. So we do have a list of medications for us to take that are approved or not approved because of the effects they have in flight. However, for our patients, we are giving them a ton of medications, and we are mostly concerned about medically treating them instead of, is this going to accelerate or make them tolerate or not tolerate acceleration more? So that's, again, something else we have to sometimes consider. Sedentary lifestyle. So if you're not in shape or don't have any physical conditioning, can't handle those G forces, that can affect you. Smoking also, just the compensation mechanisms that the body has are lacking from that, those kind of CO, mostly toxicity. So there's some signs and symptoms. These people that have, like, let's say I have a closed head injury and I'm really worried about ICP, I've got to be prepared that I'm not going to be able to control, but I'm going to have an increase in ICP. So I have to make other means of how to mitigate other increases in ICP. For instance, on that one, it's making sure they're sitting in line with no kinks in order to impinge cerebral blood flow. I'm sedating them so that they aren't having pain. Nausea, vomiting is a huge increase in ICP. So just trying to make them comfortable so that they don't have to worry about this. But some of this stuff, like the cardiac output and the ICP, tachycardia, shifts in fluid, I might need to orient my patient differently in the plane if I can, in order to have the G forces affect it in a non or lesser negative way. The one that always terrifies me, and I load patients backwards, is pregnancy. So if my patient is near delivery, I might actually load them in feet first. So when the plane takes off, that pressure is pushing the baby further into mom instead of further out of mom, because we have a saying that we don't multiply or divide in flight. So not delivering a baby in an aircraft, as you could see from that very small space. So this is just kind of to wrap that all up together, is we have this ideal gas law, and this is taking all the different gases into account so that we know how they're going to react all together when we get up into altitude. So again, this is just an introduction to all these different things that we consider in flight, but unfortunately it's not just take the ICU and put it in the air and then put it on the ground somewhere else. There's lots of different things that sometimes will influence to make a different medication or medical management in general decisions in flight. So that's why we might want things a little bit differently for transport than what necessarily worked really well in the hospital. So to kind of close it all up and wrap it in a nice little bow, we have to deal with very small spaces for the most part. We have limited access to both the patient and equipment. So that's why it's really important for us to have really good packaging and assessment and be able to reach everything that we need before we end up leaving. Sometimes we have to leave things behind. So we have to make sure that our equipment and our space is really well managed. I'm sure you guys realize that also in expedition. Like, I don't want to carry a 50-kilo pack, so I might have to make decisions on what I can take and what I have to leave behind. The environment is very loud, so this can impinge both communication and increase my fatigue. So we have to figure out if I have different facial expressions or hand signals or other kinds of things that we can do for each other for proper communication. Communicating with your patient sometimes can be very difficult. So you might be writing notes or pointing at things or other kinds of things because they are not on headsets, and it can be hard with a helicopter helmet being able to move it to talk to them. Temperature, we have to really keep track of temperature for both for us and for our patient. So oftentimes we will be monitoring invasive temperature, so esophageal or rectal probes. Sometimes we're able to get away with a skin probe, but if it's a really sick patient, we want really accurate active monitoring for temperature at all times. Movements, so think we've got to move them in ambulances and then load them onto the aircraft and then out of the aircraft. And it's not like a nice ICU bed where we just roll it down the hallway. There's lots of different things going on. It's a very active, you've got to lift people all the time and move them appropriately. And then additionally, we have movement inside the transport vehicle. So vibrations, turbulence. If turbulence is too significant, we don't fly, and it can be dangerous. If we have an unstable cervical spine fracture, I might take them a different route because I don't want to make that worse by some turbulence that I cannot control. Then the G forces, we might turn them a different way or provide some different medications in order to help them tolerate G forces more. And lastly, altitude, we have got to think about what are we pressurizing our aircraft to, if we can pressurize it at all, or if we need to fly at a different altitude because of cooler temperatures or higher temperatures. How much oxygen do we have, not just in the air, but do I have enough for both me, the crew, and for my patient to mitigate if I need to? And then what kind of barometric changes are happening? And do I need to monitor any compartments that are not able to vent out or equalize their pressures? And that is everything that I've got. If you guys have any questions at all, whether it's flight or other wilderness related, I put my email and also my Instagram handle on there. I'm more than happy to reach out and network, and I love talking to everybody about this kind of stuff. So if anyone has any questions, I'd love to share more with you. But thanks.
I have a quick question. Do you
Of
have
course.
like a particular experience as a flight medic that stands out to you that you wouldn't mind
Oh,
sharing with the group?
I have lots of experiences that I could sit here all day. One of my stories that everybody always loves to hear, I was flying out in Alaska at the time, and we responded out to this. So we're familiar with Alaska. So we've got the Aleutian Islands and Juneau and Sitka down here. And I flew from Fairbanks all the way out to almost Russia, this little tiny island. And it was for a woman with abdominal pain. It was 3 o'clock in the morning when we got dispatched, and I had been, I think it was my 8th flight straight that I hadn't had any sleep or anything. My partner and I were kind of at that like goofy, delirious stage of our our shift, and we do an abdominal assessment on this. I think she was 47 years old, and we have these little tests for fluid and other things, and it came back with ferning, which if anybody recognizes that, that means amniotic fluid. And so I'm like, oh, hey, you're having a baby. She had no idea, of course. And so we had no prenatal care or anything. We do carry a tachometer, or we did at that job. And so I tried to put the tachometer on, couldn't get a reading on baby, so we didn't even know if baby was alive. So of course I'm with a male partner, and as a female, the guys always make me deliver the babies. So I'm going down to catch, and I'm trying to get this mom all jazzed up to push, and she's pushing, and I know that this kid is not coming out head first. And I'm like, well, this is not going well. So I call med control and get Doc on the phone, and I'm like, hey, can you talk me through a footling breech delivery? Because I just never actually done one, but it's been a while for training. And she's like, yeah, no problem. So Doc is talking me through delivery, and we thought it was a knee, and all of a sudden, ta-da, it's a hand. And I was like, Doc, that's a hand. And she's like, no, it's a foot. And I'm like, you don't understand, I'm delivering hand. And she said, well, put it back. I'm like, okay. So try to reduce the arm back in, and she's talking me through how to do an internal rotation of this baby. And that is finally when we realized the baby was alive. The other good thing that we got out of that was the hand had creases on it. So the hand, we knew that he was what we call fully cooked. So he was term, and I didn't have to do a lot of pre-me resuscitation. But we tried for 45 minutes, and I got really friendly with this mom, but could not turn the baby. And called Doc, and I was just like, I've tried everything you've told me to, and I can't turn the baby. And she said, all right, well, load her full of tocolytics and fly her here. The closest hospital for us this is in the Learjet, was a 4-hour flight. And so we had to try and get mom comfortable and put her high Trendelenburg and keep the baby off the cord and everything, and give her a lot of tocolytics and make her comfortable for 4 hours of flying. And that's just flight time. So we had ambulance rides on each side. And then we got to the airport, and dispatch forgot to give us an ambulance. So we sat there for another 45 minutes and waited for an ambulance to pick us up. And then we rolled her straight into the OR, and they C-sectioned her right there, and healthy, happy, beautiful baby boy was the result of that. So I like that story just because everybody turns out okay. But I have to admit, I have lots of horrors about hands coming out of people since that call.
Oh my goodness, what an adventure.
Yes. So as you see, it's more than just picking up MVAs or traumas off the side of the road in mountains, but I've picked up some bear attacks. So bears like to do the same injuries, it seems, are very common. So we had a guy walk to our helicopter holding his like degloved hand face in his hand, and he just walked on the helicopter, and we transported him, and I think 30 surgeries later, they were able to put his face back on from the bear attack. So yeah, lots of different exciting things. Sometimes you get things that you get really make a difference, and other times it's just a little septic old lady that you just get to hold her hand and try and medically manage her. So I like it. It's a little bit of everything. I do admit that I really like being out in the wilderness and doing all these cool mountain medicine and things more. This is just my full-time job, but I do like, the patient care and helping all the people. So
You are awesome. That was such a good talk. I have a couple questions.
of course.
Everybody else, feel free to jump in and interrupt me because I will just sit here and yap. So I was really curious. Maybe you don't know this one, but the jump from like 20 to 22,000 feet on your like little graph with the
Sure.
altitude and like sort of the just a survival time there, if you will. That's a crazy amount of time to me to go from like, oh, it's over 30 minutes to I think it was like 5 to 10. That's just such a big jump for 2,000 feet, I feel like.
I'm sorry, where are we're looking at here?
At the very bottom, like those two numbers between 20 and
Oh, sure.
22,
To the
like that's
greater
insane.
Yeah, there's a big pressurization difference just in terms of your useful consciousness, that 10 minutes to 30 minutes, and again, it really depends on the person, if you're able to tolerate those as you dip in hypoxia and other kinds of things. But the way that graph works is you have that useful consciousness, and then once you get above 20,000 feet, it goes exponentially up really quickly. So it does make a big difference, but man, I will tell you that 5 to 10 minutes, like I would take that any day over 15 seconds. So I personally like flying below 30,000 feet for a lot of these reasons. I've only been in a rapid decompressionization once, and not something I'd like to repeat, but It does make a big difference. I actually wear a watch now when I fly that it alerts to pressurization changes. So it gives me like a little bit of a clue in. But mostly it does, like, you have clues if you're really paying attention to yourself of like, oh, I'm popping my ears more than normal, or I'm feeling a little bit more sinus pressure than normal, or you have some things that after you're up at these pressures all the time that you understand what pressurization should feel like. But yeah, so that 20,000 feet really does make a huge difference.
That's crazy. I can't even imagine. Oh, oh, geez. Okay, I lost for a second. Can everybody hear me? Okay.
Oh, yep, there you are.
Cool. Awesome. I'm back. Yeah, I was saying that that's crazy. I was also kind of curious, can you sort of walk me through, obviously it's super case dependent, but you get the call, you're headed out. Like there's stuff I would run through if I'm on the bus that I know I'm gonna do before every patient. I have to imagine that's pretty different for you, or maybe not. Maybe it's the same.
Yeah, so just to kind of start, I didn't really talk very much about this, but our kind of, we call it a flight flow of how things, the getting a call and how that all progresses. We start by, when we get in, we call it a pre-flight activation or a pre-flight alert. But we get a text message or a call from dispatch or a comm center, and it tells us very limited information. So the only patient related information we get is their weight. And so that is so that we can make the decision of fuel and space and other kinds of things, if we're able to complete it. And then it gives us a location to go. So we get together all as a crew and we look at weather and fuel and other kinds of maintenance issues, other stuff on the aircraft or around us. Like what my company right now, we have fatigue timeouts. So if I've flown so many really critical patients that my brain is fried, or if I've been up for a certain amount of time, they have mandatory stops so that we don't make medical errors or we don't get in situations that we're doing stupid things because we're tired. So we go and we do all of these risk assessments. We look at the weather, if it's good to be able to get to where we're going, and then also be able to take them somewhere from there. So it's a really complicated process of looking through all of these different factors. Then once we all three decide to go, there's kind of a saying in medevac of all to go, one to say no. So if one person has the littlest inkling of saying that they're not comfortable with the flight, we turn it down. It is really difficult, especially getting started, saying you're thinking there's someone on the other side of this phone that really needs my help, and I might be the only person making the difference between life and death, or if they're getting the care they need or not, or even limb or significant disability, all those kinds of things. But taking the patient part of it out, you're thinking of it as, can I safely do this? Because if I can't safely do it, then I'm not putting just this patient in danger, but my entire crew, maybe the entire public, other kinds of things. So you have to kind of think of it in terms of an analytical sense instead of a patient sense. And that can be really difficult when you're making those decisions. And that's a lot different than it was in the ambulance, because I never had an ability to say, I'm not going to take this call when the tones are going off on the ambulance or in the station. So once you decide that it's safe and you all are like, let's go, then as you're getting going to get all of your bags and stuff in the airplane or wherever you're going, then you'll get an information alert from dispatch, and it will tell you a chief complaint, maybe some interventions. Normally we are just told like if they're intubated or any other certain medications or special equipment. And so then when we're going, usually there's a response time, and we call that a dead leg because we don't have patient on board. You're doing all sorts of calculations. As I showed in that picture at the beginning, we are making drips, we're getting our vents set up and ready, we're getting all of our stuff that we think we're going to need. And we usually go into the scene with more than what we think, and then we can always put it away. It's easier to put it away than it is to try and get it out with the patient involved. So going over prepared. I am a big fan. Have like this big 2-inch roll of tape that I keep wrapped on my belt, and I put all sorts of medications and calculations for different patients on that piece of paper. and then, or on that piece of tape. So I know that if I need to RSI and intubate them, what's my tube size, what's my medications, I'm going to do that. So that when I show up and I get that patient, I have most of the work done for me. So when I'm stressed out and I have now it's a real patient, I have that stuff that's high likelihood of me screwing up under stress. It's already done, so I don't have to worry about it. And we do double check all of our medications and interventions between both partners so that there's lower likelihood of making any errors. Does that answer your question?
Super answered my question. Thank you.
Awesome. Yeah, of course. Anybody else have any questions? Was I just that good that I talked about everything?
You did cover a ton of ground. Like, it was
Yeah,
awesome.
I tried to cover a little bit of everything in the short amount of time we had.
And looking in the chat, there's a comment, not a question, from Leslie, who says thank you, and he's getting ready to sit for their WPC and
Perfect.
found it very helpful.
Yeah, Leslie, I good luck on the test. I'm writing questions for it, and I was on the beta testing team. I wish you the best of luck, and if you need any help with it, feel free to reach out to me. I'm more than happy to give you any guidance I can. But it's a good test. The same company.
If there's any hard questions, Kristen wrote them.
That wouldn't be too far fetched. The same company that puts on the WPC puts on something or has a test that's been around forever called the FPC, and that's the flight paramedic certification. And that's actually required for all flight providers to pass and hold that certification. And it just goes over all of this this critical care, and the flight physiology is stuff that you have to be knowledgeable and test on before you and most companies require that you have it within 2 years of starting to fly. You have to be able to pass that and have that certification. So yeah, of course, happy to help.
Awesome. Well, if anybody else has any questions, I think we're sort of dropping here, so
Awesome.
probably go ahead and call it.
Sounds
Kristen,
great.
thanks so much for your
You're welcome.
time. You are awesome and a pleasure to listen to. And I
Happy
hope
to.
everybody has a great rest of their day.
Yeah, thanks for the opportunity, and thank you all for your time. Appreciate you tuning in.
Thanks so much, everybody.